Thank you. Thank you for joining, and thank you for giving me a chance to talk. What I have done is I have developed a presentation. The way I talk to a new patient, when I see a lung cancer patient for the first time, I bring up certain points, because I feel that the patients need to know as they get their diagnosis and how we decide treatment. So hopefully this is what you were looking for, but please stop me. I have a habit, Ms. Pickworth can watch for it. I keep talking, so perfectly fine for you folks to interrupt me if you have any question. I'm currently at Henry Ford, but I feel I'm a Metro Detroit doctor because I used to be at Karmanos until 2017. And then I moved to University of Michigan for 3 years. And then 2 years ago, I joined as division chief. And hopefully this will move. So I always start off when I see a new patient as to discussing what is cancer. And I'm certain all of you know this, but I like to highlight this issue. So we are made up of multiple cells. So in the tip of my little finger, there could be up to 1 billion cells. These are generally round in structure. And in each of our cells, we have 2 sets of genes, one from our father, one from our mother. And in every cell of our body, we have the same set of genes that we inherited from our parents. And it's the genes that tell our cells what they are supposed to do. During our lifetime, we can pick up damages to these genes. The damage could occur through many different things in the environment, diet, water. And one of the things that can damage the genes, particularly in the lung cells, is smoking. Now, I know many of you have never smoked or didn't smoke for a very long period of time, and I'll come to the never smoking population who develop lung cancer. But smoking can damage genes, and these blue lines are supposed to represent gene damage. And then what happens is that now, a couple of things to note is not everybody who smokes gets gene damage, and why some people get gene damage and others don't, we don't understand. And if the gene damage that every person, if the person does get it, can vary from one individual to the other. So it's not the same gene damage that you get. So why certain individuals get one pattern of gene damage, another a different pattern, we don't understand. Now, just because there's gene damage doesn't automatically mean there's a consequence. There is enough remaining normal genes that can provide normal commands to the cells, and the cells can function properly. But if the damage occurred at certain points along the genes, the damaged genes start sending wrong commands to the cells. And that's what makes the normal cells flip to cancer cells. And there are 2 main features that distinguish a cancer cell from a normal cell. A cancer cell keeps on multiplying. 1 forms 2, 2 forms 4, 4 forms 8. Normal cells can also multiply, but they will only multiply under certain circumstances because the normal genes regulate that. And after they multiply up to a certain number of times, the normal genes tell the cells to stop multiplying. In the cancer cells, the damaged genes tell the cancer cells to keep on multiplying without any rhyme or reason and don't send in the stop signal. Please ignore all this part. Focus on the fact that these cancer cells are dividing and forming a tumor mass. And then some of the cancer cells detach from the main mass, get into the blood vessels, and through the blood vessels can travel to other parts of the body and start growing there. Normal cells do not have the capacity to detach from where they're located and go to other parts of the body and start growing in those other areas. Cancer cells derive that ability, at least some of the cancer cells, because the damaged genes tell them to do so. So any cancer is our own tissue that is growing when it is not supposed to, and where a portion of the cancer can learn to detach from where it is located, go to other parts of the body and start growing there. If this process starts in the lung, it's lung cancer. If it starts in the kidney, it's kidney cancer. If it starts in the colon, it's colon cancer. Even though each of these are cancers, the way each of these cancers grow, the areas that they spread to, and most importantly, the treatments that they respond to are very different from each other. So the way we treat lung cancer is not the way we treat kidney cancer, and is not the way we treat colon cancer. And it is important to note that, because you may have well-meaning friends and relatives come up to you and say, oh, in my cancer, they did this. And just because something works in one type of cancer doesn't mean it works in every cancer. Even in lung cancer, there are different types of lung cancer. So Ms. Pickworth has a very specific mutation in her cancer called BRAF V600E. So some of the treatments that we may consider her in her case may not be applicable for other lung cancer patients' cancer. One other thing I want to go back to this slide, because when I say acquired gene damage, a lot of us think of inherited gene damage. This is not something that patients have inherited, but during their lifetime, because of certain exposures, they acquired these gene damages. And this is not something that you're going to pass on to your children. If you test the same genes in the normal lung cells, you're going to find those genes are normal. So when you test the cancer, the genes in the cancer, they are abnormal, but the same genes in the normal lung cells are normal. So this is for some reason in the lung, in the lung tissue where the cancer started, that those cells in that tissue acquired these gene damages. And that's what flipped the cells in that particular area from normal to cancer cells. So a lot of people get a little confused when I say genes. They are worried that they're going to pass this on to their children. This is not inherited, it is acquired. And I just want to finish up by saying, when you look at never smokers, there are a variety of factors that can cause similar gene damage as cigarette smoking. One is, of course, secondhand exposure. There's exposure to radon, and then there is exposure to environmental pollutants. Just as an example for environmental pollution, we think of industrial smog and car exhaust pipes, smoke and all that stuff, which can cause it. But there is now more and more focus on small particulate matter that can be present in variety of environments. An interesting example that is kind of closer to me is that in the Asian cooking, including Indian cooking, there's a lot of frying and there's a lot of smoke that is produced while doing that cooking. And we tend to live in smaller dwellings. So we get exposed to that smoke over a long period of time. And that can also cause this kind of gene damage. And in fact, the WHO has now recognized this small particulate exposure as a carcinogen. So, but by the way, one other thing, sorry, I keep going back. This is not a process that happens one fine day. It's a process that happens over years. So there are certain patients who I see who tell me, why are you bringing up my smoking? I stopped 10 years ago, 15 years ago. Once the process is set in motion, whether it is related to cigarette smoke or some other factor, once it reaches a certain threshold, even if you withdraw the factor that caused it in the first place, it is self-sustaining and it can continue. So even though you may have somebody may have stopped smoking 15, 20 years ago, doesn't mean that smoking didn't initiate that gene damage process that reached a certain threshold. And then even though the individual stopped smoking, it was self-sustaining. So important point to note is this is not something that starts one fine day. It's a process that goes over years. And I'll come to this issue a bit later on. So one of the common questions I get asked when I see a patient, and being a medical oncologist, many of the patients I see already have advanced stage disease. So only about 30% of patients have early stage or stage 1 or 2 cancers. Majority of the patients have stage 3 or stage 4 cancer. And the question is, how is it possible? I'm feeling overall pretty fine. How come you're telling me that the cancer has already spread either to the lymph nodes in the middle of the chest or has spread to other parts of the body? We have 2 lungs. We don't need 2 lungs. People have run marathons on 1 lung. So you could have a lesion, a spot growing in your lung and may not know about it because it doesn't affect breathing. It doesn't cause any coughing. The other issue is that we don't have any pain nerve fibers in our lungs. So if I slap myself on the hand, I feel the pain because there are pain nerve fibers on my hand that convey the pain signal to my brain. There are no pain nerve fibers in the lungs because we breathe, so our lungs move. And if we had pain nerve fibers, we would be in pain all the time. And so because we don't have pain nerve fibers and because we have 2 lungs, many times we don't realize there is a lung cancer that has started. And it is only when it has spread to other areas that it causes symptoms. And then that's how the diagnosis is made. And so this is one of the reasons why lung cancer screening is very important. And I'll come to that issue a little bit later on. This doesn't completely explain, but these are the two main reasons why many of the patients have advanced stage disease by the time they're diagnosed. Now, lung cancer technically can spread to any part of the body, but the 6 major areas, and I'm sorry, this lists only 5, 6 major areas that lung cancer can spread to is the lungs itself. So it can start in one lung and spread to the other lung. There is also something called as the pleura that surrounds each of our lungs. Think of a thin wrap that surrounds each lung, like a saran wrap that surrounds a sandwich. It is so thin that you can't even see it on a normal CT scan, and it has folded on itself. So there's a tiny space between the two folds, and there is normally a tiny amount of fluid. Again, so little that you can't see it on a normal scan. And so the cancer can spread not only to different portions of the same lung or other lung, but also can spread to the lining around the lung called the pleura. It can spread to the adrenal glands. Those are organs that sit on the top of our kidneys and make endogenous steroids. It can spread to the liver, the bones, and the brain. Now, mind you, it can spread to other parts of the body. And in any particular patient, it may not spread to all these areas. Why? In some patient, it spreads to the brain, but in others, it doesn't. Why? In some patient, it spreads to the liver, and in other lung cancer patient, it doesn't. We really don't understand. And so when we do the scans, we are doing scans to detect, at least at the time of diagnosis, we are doing the scans to properly understand what is the extent of the spread of the cancer. Is it limited to the lung? Is it spread beyond the lung? And if it has spread beyond the lung, which organs? And so the reason we do brain MRI, CT scan of the chest, and PET scan is to ensure that we have comprehensively analyzed these areas. And sometimes patients wonder, why are you not scanning me from head to toe? Technically, lung cancer can spread to any part of the body, but generally, these are the 6 areas that lung cancer tends to spread to. Now, once you have diagnosed lung cancer, and once the first thing as a medical oncologist I want to know before I decide any sort of treatment plan is 2 factors. One is something called as performance status. Performance status is a general estimate by the doctor of what is the functionality of the patient. So you can have 2 lung cancer patients with the same extent of disease, but one patient walks in and another patient comes in a wheelchair with 2 liters of oxygen. And even if they have the same extent of cancer, the prognosis of the patient who comes in a wheelchair with 2 liters of oxygen is very different than the patient who walks in. And that assessment of now I've given an extreme example, but we make an effort to understand what is the functionality of the patient, and not only understand what the functionality of the patient is today, but how is it relative to 2 months ago or 3 months ago? What I mean by that is somebody may have, let's say, a back problem, which is why they can't walk long distances and therefore have to come in a wheelchair. And that really hasn't changed a whole lot. And that's why they're coming in a wheelchair, as opposed to somebody who used to run marathons and now has a hard time even climbing a flight of stairs. Those are 2 different performance statuses. That is, that person who used to run marathon and now has a hard time climbing even one flight of stair actually may have a worse prognosis than the person who has had back problems for years, and that really hasn't changed, but otherwise the patient's functionality is about the same. So that continues to be, despite all the advances, that continues to be an important factor in deciding treatment. And the next thing is stage. So you may hear your doctor say, I need to stage your cancer. And what stage indicates is what is the extent of spread of the cancer. So stage 1, and this is really simplification, but stage 1 is when the cancer is limited to the lung with no evidence of spread anywhere else. Stage 2, it has spread to lymph nodes that is closer to the lung. Stage 3, it has spread to the lymph nodes. This would be stage 4 actually, but stage 3 is when it has spread to the lymph nodes in the middle of the chest, or the cancer is actually invading in the middle of the chest. And stage 4 is when it has spread to different parts of the body, including other portions of the lung. Now, the reason why we think of in these 4 stages is that not only is the treatment different for each of these 4 stages, but the prognosis is different. And the reason why the prognosis is different is that the probability or the chance that it has spread somewhere else increases with each stage of cancer. So in stage 1 lung cancer, there is a very low chance that the cancer has already spread to some other parts of the body, but too small to be seen on the scans. And because that probability is low, we consider taking it out, surgery, or in some cases, radiation as the only treatment. In stage 2, the risk that it has gone somewhere else, even though the scans look perfectly fine, there is a greater chance in stage 2, there's a greater chance in stage 2 that has spread somewhere else, but wherever else it has spread, it is too small to be seen on the scans. What do I mean by that? For us to see something on the scans, it has to be at least as big as the tip of my little finger. And in the tip of my little finger, there could be up to 1 million cells. So if the lung cancer has spread, let's say to the liver, but it is only 500,000 cancer cells, it's not going to show up on any of the scans, even whether you do PET scan, CT scan, MRI. And so the chance that it has gone somewhere else is higher with stage 2 than in stage 1. And therefore, in stage 2, we normally don't do just surgery. We tend to add a treatment that goes everywhere. And to a large degree in stage 2, it is chemotherapy, though there is more and more use of immunotherapy and other agents. In stage 3, it's a certainty. I mean, there are always exceptions, but it's a certainty that it has gone somewhere else. And so it is not just about treating what we see on the scans, but we also need to ensure we are doing a treatment that is taking care of the cancer that has spread somewhere else, but not big enough to be seen. And so in stage 3, we very commonly use radiation to cover all these areas, because this would be too much for a surgeon to go and remove everything. But only treating what we see on the scans is not sufficient. And so usually we add chemotherapy, though there is greater use of immunotherapy also in stage 3 lung cancer. And in stage 4 lung cancer, we already can see cancer somewhere else. So it is not just an issue that we know that it is somewhere else but can't see it, but now we can actually see it. So the main difference between stage 3 and stage 4 is in stage 3, we are certain it is somewhere else, but not big enough to be seen. And that is good. Whereas in stage 4, you can already see it somewhere else. And this is sort of the broad approach. Mind you, this is a slide I made back in 2013, and things have obviously changed in terms of what we do now. But broadly speaking, in stage 1, we still use surgery, sometimes a radiation if the patient can't undergo surgery. In stage 2, we normally do surgery followed by chemotherapy. 2 issues that have changed since 2013. We are now doing more and more upfront chemotherapy with immunotherapy before even surgery. The traditional approach was surgery first and then chemotherapy. But there is more and more data that maybe if we started a treatment that goes everywhere, because remember why we are doing the chemotherapy after surgery, because there's a chance that the cancer has spread somewhere else. So by giving treatment that goes everywhere, not only are you addressing the cancer in the chest, but also addressing cancer at other places. So there's more and more use of chemotherapy plus immunotherapy before surgery. But the traditional approach is surgery followed by chemotherapy, and we are using more and more immunotherapy in the stage 2 setting. In stage 3, because it has already spread to the middle of the chest, we usually don't do surgery because it would be too much to remove everything. And in those patients, we do radiation and chemotherapy. Again, a common theme, immunotherapy is being used more and more in stage 2 and stage 3 disease. And then in stage 4 disease, which I'm going to come to later on, we use a variety of different treatments. So this is where we are in terms of stage 4 non-small cell lung cancer. By the way, today I'm only talking about non-small cell lung cancer. I would love to do another presentation on small cell lung cancer. Even though both are lung cancers, the way we approach small cell lung cancer is very different. It's almost like a different cancer, and what is applicable for non-small cell is not applicable for small cell. So 85 to 86% of all lung cancers diagnosed in the United States are non-small cell lung cancer. About 15%, a little less than 15% are small cell lung cancer. So mind you, what I'm talking today is non-small cell lung cancer. So when it is stage 4 in non-small cell lung cancer, the two primary treatments we are considering is something called as targeted therapy or immunotherapy. And many of us refer immunotherapy as IO, taking the I and the O, and it is labeled as IO. And before we decide this treatment, it is quite critical that we do some molecular testing and testing of the cancer to understand what are the features of that patient's cancer. And based on that, there is a more personalized way of treating the cancer instead of what I used to do when I started doing this back in 2000, where everybody got chemotherapy. We still use chemotherapy, but almost always these days, there are always exceptions. We are using it with immunotherapy or we are doing targeted therapy. Because it has become very critical that we do testing of the cancer beyond just making a diagnosis, that is beyond the biopsy, and then the biopsy is looked at by the pathologist. There has to be additional testing done, and many times that testing is only ordered by the medical oncologist. It can take up to a month, a little bit longer in some patients, before we start treatment. And that period can be extremely frustrating for newly diagnosed patients, because the patients feel, you've told me I have lung cancer. I want treatment started yesterday. Why are you now telling me you have to do these additional tests? What is important to remember is that this lung cancer that was diagnosed, let's say today, didn't start yesterday. This had been going on for some period of time. It is only now that we know about it. Now, that doesn't mean we take our own sweet time, but this is not a cancer that grows by the minute like leukemias or certain leukemias, certain lymphomas. And so it is important that we get the proper testing done and then start the right treatment for that particular patient rather than rush into something that is not specific. So as frustrating as it is when a patient is newly diagnosed, and it is very critical that we do the proper testing and start the right treatment. So what is that testing? And that testing is actually something called as next generation sequencing. This is an example of something called as ALK translocation. I can get into the specifics of it a bit later on, but this is one of the gene mutations that we want to test for. I only showed this particular mutation in the lung cancers that we can see because we used to use different tests in the past to detect it, but now we use something called as next generation sequencing that simultaneously analyzes, and the panels are different in different laboratories. At Henry Ford, we have a panel of 170 genes. When I was working at University of Michigan back in 2019, they had a panel of 70 genes. I don't know whether they've expanded that panel. If you go to private laboratories like Foundation, Caris, they analyze 600 genes simultaneously. I don't think there's a need of more than about 20 to 25 genes to be analyzed in most lung cancer patients. But these panels simultaneously analyze multiple genes. So instead of in the past checking for each mutation separately, like these are tests that will only give you answer on the ALK, but it won't give you answer on others such as BRAF or EGFR. Whereas when you do the NGS test, it simultaneously tests for all these genes. There are other nuances about NGS testing that I can get on later on. But NGS testing can be done two different ways. It can be done on the tumor biopsy, and occasionally when a biopsy material is obtained, you can make the diagnosis, but it may not be sufficient amount of tumor to get the NGS testing done. And occasionally we have to do a repeat biopsy to get the next generation sequencing test done. So it can be done on tissue. That can take 2 to 3 weeks to get the results back. But nowadays, more and more, we are doing blood-based testing. About 70% in general, about 70% of stage 4 lung cancer patients' cancer sheds its DNA in the blood. And so you can collect a blood sample, send it to a private lab, which then extracts tumor DNA and can do the same testing, next generation sequencing on that tumor DNA obtained in the blood. A couple of things to remember. The advantage of the tumor DNA testing is that the results come back much quicker. They can come back in 7 to 10 days. So once you get a result, you can start treatment. The problem is in about 30% of lung cancer patients, the cancer may not shed the DNA in the blood. So if the blood test is positive for a particular mutation, you can use that to start treatment. But if the result is negative, you still have to do the biopsy, the tumor NGS testing. And so what I tend to do in stage 4 lung cancer patients is send both the blood and the tissue. I know insurance companies hate me for that, but that just helps me learn if the patient's tumor has a particular mutation much earlier. And I just feel like I have 2 shots of go at the goal to get those results back. The other thing to remember is that there are at least 7 genes right now, 8 genes right now for which we have FDA approved drugs. But there are other gene alterations that as yet we don't have a drug available, but quite likely in the future, we will have drugs available. So what do I mean that we have drugs available? And I'm going to take the example of the BRAF V600E. Hopefully you can see it's a very small percentage. And this is the mutation, this blue pie on this chart, that constitutes about 2% of all lung cancers have this BRAF V600E mutation, which Ms. Pickworth's cancer has. What does this mean? This means that there is a mutation in that BRAF gene. Mind you, this gene is present in every cell of our body. But for reasons we don't understand, the gene in the lung cancer tissue got mutated, and that resulted in this BRAF substance hyperfunctioning. It is functioning at a much higher level than what it should be. And so because it is hyperfunctioning, it is making the cancer cells multiply and develop the ability to detach from where it is located and spread to other parts of the body. So we have 2 drugs that a combination of which can block this BRAF mutation. And so because the cancer is mainly dependent on that mutation, by the way, these gene mutations then result in a substance called BRAF V600E substance. And it's that substance that is making, it's not the gene, but the product of that gene that is making the cancer cells grow and spread. And that product of that gene is blocked by the combo we have. And because the cancer is heavily dependent on that substance, that hyperfunctioning substance for its ability to grow and spread, once you block it, the cancer shrinks. Now, there are, as I said, 8 different substances for which we have drugs that can target that altered substance in the cancer that is making the cancer grow and spread. And by the way, they are mutually exclusive. So if somebody's cancer has BRAF, it is not going to have EGFR, ALK, KRAS, CMET. If somebody's cancer has EGFR, it is not going to have the others. So they are mutually exclusive. There are always exceptions, but they're generally mutually exclusive. And then the probability of identifying a gene mutation that is driving, a single gene mutation that is driving the cancer is much more likely in a never smoker or what we call light smoker, less than 10 pack years. Whereas if somebody has smoked for 20, 30 years, even if they have stopped 10 years ago before they got lung cancer, the probability of detecting one of these mutations as the main driver of the cancer is about 5 to 10%. Now, what happens in those patients? What is happening in those patients is that instead of having one particular gene that is the dominant gene that is making the cancer grow and spread, in the patients who have smoked, generally there are multiple genes that have been mutated, and together their substances that they are those substances resulting from those genes together are making the cancer grow and spread. So there's not a single substance that you can give a drug to block and the cancer will shrink. Whereas in a never smoker, the chances of having a single substance that is the main driver, not to say in a never smoker, you can't have other substances that are helping the cancer grow and spread, but there's a main substance on which the cancer is dependent. And so if you can identify that, we give a drug that blocks that. And I want to make myself clear. It's not that you would always find the main substance that is driving the cancer in a never smoker and that you would never find it in a smoker. I'm just saying the chances are greater in a never or light smoker as compared to a smoker. Once we find the main substance, so we do testing in all stage 4 lung cancer patients. We don't do it only in never smokers or smokers. And once you find a specific mutation that is the main driver, irrespective of whether they are smokers or never smokers, we tend to give the targeted treatment. Now, why do I say targeted? Because the drugs that we would give to a patient like Ms. Pickworth only blocks BRAF V600E mutation. We would not give it to a patient whose cancer has this KRAS or EGFR mutation, because those drugs don't have any activity against EGFR or KRAS. So if we find EGFR, then we would give a drug that blocks EGFR, and that's why it's called targeted therapy. And then the other treatment that has made a major advance in lung cancer is immunotherapy. Now, before I talk about immunotherapy, I want to make it clear. Patients who have cancer doesn't mean their immune system is compromised or they're immune weak. Now, chemotherapy can make them immune system weak, but it's not that they developed cancer because their immune system was weak. Their immune system was perfectly normal. However, when a cancer develops, it manages to fool the patient's immune system into thinking it is normal organ. And our immune system is so engineered that it is supposed to recognize infections and cancer tissue. And once it sees infections or cancer tissue, it is supposed to attack it. So when cancer develops in a patient, it's not because the immune system is weak, but the cancer has managed to fool the patient's immune system into thinking it is normal tissue. And our immune system generally will not attack normal tissue. So because the immune system can see the cancer, but sees it as normal tissue, it is not launching an attack. And I give an example, which is probably not politically most correct. United States has tremendous defenses, great Air Force, Navy, Army, and border security. But that doesn't mean a terrorist couldn't sneak in to the country, avoiding all the safeguards we have in preventing wrong people entering our country. So your immune system might be perfect, but the cancer may be able to fool the immune system. And one of the ways it can fool the immune system is the cancer activates on the immune cells. This is represented here by T cell, something called as PD-1. PD-1 is present on our T cells because it's a brake that we have naturally, so that when the immune system gets activated to take care of infections or cancer, that activation is restricted to that area. Because if you had unrestricted activity of the immune system, it would cause damage to normal organs. And so the reason we have these natural breaks in our immune system is to ensure that the immune system does its job, but nothing beyond. The cancers kind of hijack that natural brake system that exists by activating the PD-1 And that makes it difficult for the immune system to see the cancer as cancer. And because the PD-1 gets activated, the immune cells start thinking that what they are seeing is not cancer, it is normal tissue. Now, this is only one of the ways that cancers can fool the immune system, not the only way, but this seems to be an important way. And therefore, there are now drugs. And the way it activates the PD-1 on the cancer cells is because it has something, it starts showing up on the cancer cells called PD-L1. And when the PD-L1 binds to PD-1, that's what tells the immune cell, hey, I'm a good guy, don't attack me. It is fooling the immune cells that I'm a good guy, don't attack me. So there are now drugs developed like Keytruda that block the PD-1 on the immune cells, or you have drugs like Tecentriq that block the PD-L1 on the cancer cells. At the present time, we don't know that it is any better to block the PD-1 or the PD-L1. They are about the same. But basically what you're doing is you're preventing the PD-L1 on the cancer cells from binding to the immune cells, the PD-1 on the immune cells. Now the immune cells are not being fooled, and now the immune cells can see the cancer and attack the cancer as they are supposed to do. Now, this is where we have to test the cancer for something called as PD-L1. This is the PD-L1 that is present on the cancer cells. Because more the PD-L1 on the cancer cells, greater is the chance that the cancer is using this strategy to fool the immune cells. And therefore, when the PD-L1 is high, and this is the high level, this is an example where there's no PD-L1 present on the cancer, that immunotherapy by itself can do the job. Again, nothing is 100%, but if the PD-L1 is high, we use immunotherapy by itself. And if the PD-L1 is low, rather low, here in the middle, or zero, that's when we do chemotherapy and immunotherapy together, because the idea there is the chemotherapy is supposed to attack the cancer directly, and the immunotherapy is supposed to activate the immune system. One thing I forgot to mention is that the PD-L1 result comes back much earlier before this NGS result. However, the PD-L1 result only has to be viewed in the context of the next generation sequencing result, because the PD-L1 result has a different significance if we find, say, EGFR or BRAF. It doesn't have the same relevance, the PD-L1 result, if we found one of these. So PD-L1 is acted upon or is considered in deciding treatment only after we confirm that we have not found any of those 7-8 genes for which we have a targeted treatment option. So many patients ask me, oh, my PD-L1 is high, just start me on immunotherapy. No, we have to wait for the next generation sequencing result. If we identified one of the 7-8 genes that can be the main driver of the cancer, then we are going to use targeted therapy first, because that is felt to be the better treatment as opposed to using immunotherapy. One may use immunotherapy down the line, or when I say immunotherapy, these drugs like Keytruda, there are many new immunotherapy drugs in development, but the currently available immunotherapy drugs are only used if the NGS testing does not reveal a specific gene alteration that can be targeted with a specific targeted therapy. One important thing to remember is you may hear your doctor say, I'm going to review your case at Tumor Board. Even in stage 4 lung cancer, where medical oncologist is the main person managing the case, we have to take the advice of surgeons, radiologists, radiation oncologists, pathologists. We all at Henry Ford meet every Wednesday morning at 7 and review almost all new cases. And many times patients who have been managing, when new issues come up, we discuss as a team, and that Tumor Board recommendation can be very critical in taking care of the patient. So if you hear a doctor tell you, I'm going to discuss it at the Tumor Board, this is what it means, because there are times when you need other specialties to help you out in taking care of the patients. And this is why I wanted to emphasize the management of lung cancer patients, particularly stage 4 lung cancer patients, is based on several factors. It's based on what is the performance status of the patient. Of course, stage is stage 4 in advanced stage patients. And then we have to do the tumor testing, not only know that we have lung cancer, but then we have to also figure out whether the patient has what sort of mutation the patient's cancer has, and whether the PD-L1 is high or low. One other factor, I think, and I'm sorry I'm going back and forth, I forgot to mention is one important, I just put here non-small cell lung cancer. Please note that there are two major subcategories of non-small cell lung cancer, something called as adenocarcinoma and something called as squamous cell cancer. And the treatment is a little bit variable depending upon adenocarcinoma or squamous cell. This is broadly applicable to most non-small cell lung cancers, but there is some variability based on whether you have squamous cell or adenocarcinoma. So that is kind of a broad idea about how we take care of stage 4 lung cancer patients. One site of disease is brain mets. In the past, we had to rely on surgery and radiation to take care of brain metastases. That is because in all of us, we have something called as a blood-brain barrier that limits the amount of drug that you give by mouth or intravenously in terms of how it reaches the brain. We now, many, not all, I have to emphasize, many drugs that we use do cross the blood-brain barrier. And this is one example of a patient I took care of back in 2014. This patient had brain metastases as well as something called as leptomeningeal metastases. And she actually came from Indiana for a clinical trial we had of this drug. Now, this drug is approved. At that time, it was in clinical trials. And as you can see, 6 weeks later, there was complete resolution of these brain metastases. This is not what happens in every patient, but what I do want to say is in the past, it was routine to send patients who had brain metastases over to radiation doctors or sometimes neurosurgeons. But now we can use our drugs that we are using to control the rest of the cancer also to control the brain. And so one needs to remember that brain has a certain special status, not just because of it being brain, but because it is considered a sanctuary site, and it is possible that some of the drugs that we give may not reach it in sufficient levels. I'm going to briefly talk about some of the new things that are coming, and this is more concepts rather than specific drugs. One class of drugs that is gaining a lot of attention is something called as antibody drug conjugates, or ADCs. And what this is based on is that many cancers on their surface have a substance present that is not present on normal cells. So cancer cells have, when we do the biopsy and test the cancer, we can identify certain substances that is different from the substance I talked about that are driving the cancer. These are substances that the cancer has. It has no necessary function as far as the cancer's ability to grow or spread, but it is present, and these substances are not present on normal cells. And that disparity, that there are certain substances present on the cancer cells, has been used by scientists to develop antibodies that just bind to those substances. But in addition, these antibodies have linkers shown. I don't know how well it shows, but you can see this circle. There is a small line that connects this small kind of orange dot to the antibody. And this is called a linker. And that linker connects the antibody to these substances which are basically chemotherapy. And this is highly toxic chemotherapy that you would normally not give intravenously like you would give chemotherapies like Alimta or carboplatin. But what happens is when you link this chemotherapy to these antibodies, the chemotherapy cannot work as long as it is linked with this linker to the antibodies. When you give this whole 3-component drug, the antibody, the linker, and then the chemotherapy into the blood, the drug circulates, and when it reaches the cancer, because this antibody only binds to the substance present on the cancer cells, once it binds, it's a lock and key. It is almost like opening a door in the cancer. So it only in the cancer cells, these on the surface of the cancer cells, these substances are present. The antibody binds to that substance. It's almost, as I mentioned, a lock and key. The whole thing gets inside, and inside the cancer cell, these linkers are broken and the chemotherapy is released. So it is at the end chemotherapy, but it is selective delivery of the chemotherapy into the cancer cells, utilizing this fact that there are certain substances that are only expressed, only present on cancer cells and not on normal cells. There are several different substances that are exclusively present on cancer cells against which such antibody drug conjugates have been developed. And there is a lot of promise. There are a few drugs already approved in breast cancer, in stomach cancer, in Hodgkin's lymphoma, and several other tumors. We are expecting certain approvals for lung cancer within the next few months. Again, it will be specific. Some of these antibody drug conjugates will only be specific for certain lung cancers, not all lung cancers. Others may be much more broadly used for other lung cancers. And the other treatment that I wanted to discuss is something called as TIL therapy, or tumor infiltrating lymphocytes. As I mentioned, immunotherapy has started playing a big role, and what the drugs that we are currently using as standard of care are activating the immune system. But for a variety of reasons, an immune response, activating the immune system that is ready to recognize the cancer and attack, but the cancer is blocking it. But in some patients, even if the immune system is normal, the immune system just doesn't develop an immune response to the cancer. So you can give the drugs that activates the immune system, but if there's no immune response that has been generated by the immune system against the cancer, current drugs are not going to be helpful. So what this approach is trying to do is it actually involves removing a portion of the cancer. And in the cancer, there are immune cells present, a few at least, and they isolate that in a lab. So you remove a portion, literally do surgery, remove a portion of the cancer. It is shipped to the lab, to a private lab. The lab then dissects, cuts open the tumor and extracts immune cells, grows them in the laboratory, the patient's immune cells, juices them up with sort of substances that help the immune cells get stronger, gives them protein powder. I'm just kidding, but just makes them into a Michelin man. And that whole bag of immune cells, these are patient's immune cells, are then given back to the patient as an IV infusion. Before giving back these immune cells, there is some chemotherapy given kind of to create a space for these immune cells. And then the expectation is that the immune cells will attack and kill the cancer. Now, this is a complicated treatment. Not everybody can undergo that surgery, and not everybody can wait for that period of time. It requires up to a month to juice up these immune cells and then give it back. And then when you give that chemotherapy to create space for the immune cells, and then when you give the immune cells afterwards, there can be reactions like fever, and your blood pressure can drop. So this is not something that can be done in every lung cancer patient's cancer. But there are two things I will say: that this can be something that can be considered in at least some lung cancer patients and has the potential, and I want to emphasize the word potential. This is still being studied and we don't have full data, but has the potential of having a sustained benefit. Once you have the immune cells, it's like a vaccine, that it can then generate an immune response against the cancer for a very long period of time. And the other thing to remember is that this is early in the development of this technology, and it is quite possible over the coming years this gets refined and it becomes a lot more easier to do this treatment. Again, this is experimental right now, but the potential and the promise is quite interesting. Another type of what we call cell therapy is something called as CAR T cells. This is used mainly in blood cancers like lymphomas and leukemias, but there's a lot of work going on in lung cancer and other solid cancers also, where patients' immune cells are extracted from the blood. So you can see here they're being extracted from the blood, and then they are genetically modified, which allows those immune cells to recognize the cancer better, and then they are infused, and then the immune cells are supposed to, these genetically modified patients' immune cells can then attack the cancer. Again, for a variety of reasons, it has been very challenging to develop this technology for solid tumors like lung cancer, breast cancer, so on and so forth. It has been a lot easier to do this in hematologic malignancies. In fact, there are approved products of this therapy for myeloma, for lymphoma, but it is possible that this will come for lung cancer also. I know I've gone on for a long time. I just wanted to quickly finish up by talking about screening. This was presented in 2011. Screening right now is limited to specific individuals between the ages of 50 and 80 who have smoked at least a pack a day for 20 years and not beyond, have not stopped smoking beyond 15 years. So many of the, almost 35% of lung cancer patients who are diagnosed with lung cancer would not be eligible for screening. So that is a major limitation of lung cancer screening. There are now blood-based tests that are in studies that may detect not just one cancer, but so we are doing a study with a company called Grail. There are other companies, I don't want to promote one particular company, that potentially can detect 12 cancers, screen for 12 cancers at a time. My suspicion is this is going to be an added tool. I don't think it is going to replace CT screening, or it is going to replace mammograms or colonoscopy. And this is that blood test, and these are the 12 cancers that the blood test can detect. I wanted to emphasize the importance of clinical trials. The combination I talked about that we can use in BRAF V600E is because patients like Ms. Pickworth years before participated in a trial, and then that combo was found to be beneficial. And that's why we are able to use those treatments as standard of care today. The other important thing to remember about clinical trials is there's so much oversight that, in a sense, when you participate in a trial, you're getting the opinion of multiple other doctors, because if you qualify for the trial, that means several experts together who are involved in developing those trials feel that that is the best treatment for you. And I can tell you that the success rate of clinical trials is improving quite a bit because the science is better. And there are very few trials. There are some trials, but there are very few trials with placebo. So you're not getting a sugar pill many times when you go on the trials. A couple of other things that come up during the care of the patient. A word that many lung cancer patients dislike is hospice care, but there's more and more recognition of palliative care. Lung cancer patients, as many of you know, deal with a lot of issues, both physical, mental, social. And we medical oncologists are much better at things like scans and molecular testing, but may not be as good as at holding the patient's hand and discussing what the implication of that cancer is, because the lung cancer patients are dealing with on a day-to-day basis, not just physically, but family relationships, finances, and palliative care nowadays helps with a lot of it, not every aspect of it. And so hospice is not palliative care, or palliative care is not hospice. And so if a doctor brings up palliative care, please don't think they think that your cancer is so advanced that there's nothing that can be done. Hospice also doesn't mean that, but I wanted to emphasize the point that palliative care and hospice are not the same. A lot of patients want to know, what should I eat? Because they feel if you eat right, you can take care of the cancer better. At the present time, there is no particular diet that is shown to be beneficial in controlling a cancer in a patient who has already developed a cancer. That doesn't mean there are not diets that can help us. We just don't have that particular data for a particular diet. What I tell patients is eat healthy. We all know what healthy is. I think in our American diet, there's a little bit too much sugar, there's a little bit too much meat, but that doesn't mean you can't eat a cookie once in a while, and that doesn't mean you can't enjoy a steak once in a while, but you just need a balanced diet. I think what is even more important, I feel, than nutrition, not that nutrition is not important, but exercise is quite important because it helps in taking care of fatigue and keeping your body going. As I mentioned, one of the most important factors we consider in deciding treatment is functionality. And now, exercise doesn't mean you have to run a marathon every day, but any activity that you're doing, and small activities multiple number of times to keep the muscles going, is being found to be beneficial in variety of different things. And I'm going to just finish up by saying, please remember, the lung cancer that was diagnosed did not start a day or two before. And this has been something that has been going on for some period of time. And therefore, it is important that you ensure that you've got the best opinion. And if that means seeking a second opinion, go ahead and do that. Having said that, I do believe nowadays with the internet, you can tie yourself into a knot by going on to different sources and trying to get 50,000 different opinions. And so there is a fine balance between ensuring that you have got all the information. But I've seen certain patients, and many times the relatives of patients, wanting to almost give the medical board exam and become an oncologist, and they want to get that much information. And again, I'm exaggerating, but it's important to be knowledgeable. And I do believe knowledge is power. But sometimes I have seen that patients just get too confused and in trying to get all the information. And at some point, you have to make a decision and move forward with treatment.